Welcome everybody to the launch of the Stanford-Lancet Commission on the North American opioid crisis. My name is Richard Horton and I'm speaking to you from the Lancet's offices in London, United Kingdom. I'd like to thank, first of all, Keith Humphreys, Chelsea Shover, and a fabulous group of commissioners for a really superb piece of work conducted over the past 2 years. And I'd also like to thank my colleague Rebecca Cooney and the whole team at the Lancet for leading the journal side of this project. The Commission has drawn vital lessons from what it describes as one of the most devastating public health disasters of the 21st century in the United States and Canada. But, and this is important, I think, as the Commission also argues, this crisis could occur anywhere in the world where there is a culture or a motivation of unrestrained profit-seeking and weak regulation. Today, Keith is going to introduce the Commission to you. Chelsea will review the current and future status of the opioid crisis, and the commissioners will then look in turn at how it happened, how it can be prevented from happening again, the issue of opioid stewardship, how health systems can be designed to take care of people living with addiction, and how the opioid crisis itself can be resolved. We will have some time for question and answers at the end, so please do think of some tough questions to put to us all. And let me immediately hand over to the person who has led this project for us from the very beginning, and a big personal debt of thanks to Professor Keith Humphreys from Stanford. Keith, over to you.
Thank you so much, Richard, and thank you also, Beck Cooney and everybody at the Lancet who have been terrific to work with throughout this process. This was a incredibly fascinating, energizing project. It was at times exhausting too, but I'm delighted that we got the opportunity. As Richard said, I'm a professor at Stanford University. I'm an addiction researcher and also a sort of public policy advisor. And the reason I took this on is, COVID is obviously horrific. It's a public health disaster. It has commanded all our attention, and that is understandable. At the same time, this problem is arguably just as serious, and we have to pay attention to it as well, not least because it's gotten substantially worse during COVID. The raw numbers of people losing their lives are greater for COVID, but if you look at years of life lost, they're actually quite similar. People who are dying from opioid overdose in the US and Canada are young, and many years are being taken away. To tell you a bit about the Commission, who are we? So they're very diverse in their viewpoints and their training. People expert in addiction, of course, but also biochemistry, medicine, epidemiology, economics, law, pain medicine, psychiatry, pharmacology, and public health. There were many different roles represented in the Commission, many people in multiple roles. So there are clinicians, there are researchers, there are educators, there are public policymakers. There are also individuals with personal experience of addiction and of chronic pain. This was co-sponsored by Stanford University. About half of our commissioners are from Stanford and the rest are from around the United States and Canada. Very important context, we had funding from Stanford through a philanthropic source. There was zero industry involvement of any sort. There were no strings attached. We could say whatever we wanted to say, and we did. I also want to clarify that many people on the Commission have worked in government or are in government, and just that we are not speaking for any government that we work in or advise. We are not speaking for Stanford or any university we work at. We're not even speaking for ourselves. We're actually speaking for the Commission as a whole. We had an internal process whereby if we could not get to 90% agreement on a recommendation, we didn't adopt it. And that's a high standard to agree, and there's always a risk you just end up with the lowest common denominator. But as it turned out, as you will see, there were a large number of extremely consequential recommendations that this group, that at least 90%, and usually, by the way, 100%, felt were important to mention. Just to give you a quick bio and who you're going to hear today. As Richard mentioned, Professor Chelsea Shover, who was at Stanford throughout this process, and I was very lucky to have her as a colleague. Also very proud that she has now taken a faculty position at UCLA. She will tell you about the current status and likely evolution of the crisis. Then Professor Howard Koh of Harvard University will, after Chelsea, I will talk about how this happened regulatorily and how to stop it from happening again. And then after that, we'll have Professor Howard Koh of Harvard University. He's going to talk about what healthcare systems can do to respond effectively to people who have opioid use disorder and other opioid-related health problems. Then Professor Yasmin Hurd of the Icahn School of Medicine at Mount Sinai will talk about what's science and the translation of science we need to respond effectively to this epidemic. And then Professor David Yerlink of the University of Toronto and Sunnybrook Research Institute will discuss the promotion of better policies on prescribing opioids and on pain care. And then we will open it up for your questions. So I will turn it over now to Dr. Schober.
All right, well, thank you. And I want to start off today by offering a few more comparisons to put the magnitude of this crisis in perspective. With the latest data, over 600,000 people in the United States and well over 25,000 in Canada have died from opioid overdose since we have good statistics, which dates back about 23 years. This, for context, this totals more than all of the US and Canadian soldiers who died in World War I and World War II combined. I know we think of HIV/AIDS as a major public health crisis that we all know to be something that caused a lot of death. Well, at this point, the per capita mortality for opioid overdose in the US and Canada is now higher than it was at the peak of the HIV/AIDS epidemic in those countries. And in fact, as Keith mentioned, even though the number of people at this point who have died from COVID-19 is substantially higher, the toll in years of life lost is still larger because the average opioid overdose death results in about 25 years of life lost per person compared to an average of 10 for COVID. So more people are dying and at younger ages. Well, what's next? The mortality rate in 2020 in the US was double that of 2015. Projections since then are worse, on track to rise yet again and continue rising. And modeling done by our Lancet Commission projects that without major policy changes, the US is on track to lose another 1 million lives in this decade. I talk mostly about fatal overdose here, but that's really the tip of the iceberg. Deaths tell part of the story, but addiction affects a vast number of people, including patients, families, and communities. The economic cost is immense. But data on deaths is sort of one of the most available kinds, and that's what I'm focusing on. But just know that that's really only the tip of the iceberg. So we can think of the crisis as having 3 waves. And it's really important to note that none of these have ended. The first started in the early 90s with prescription opioids, as deaths involving prescription opioids rose. Then starting around 2010, deaths involving heroin really rose as people transitioned from prescription opioids to a cheaper alternative in heroin. Then a few years after that, and where we are now, synthetic opioids, mainly fentanyl, have largely replaced heroin in a lot of places, and now the vast majority of opioid overdoses involve synthetic opioids, mostly fentanyl. We also now see an increase in polysubstance deaths, where stimulants like methamphetamine or cocaine, other substances like benzodiazepines or alcohol, are used with opioids. And COVID-19, as Keith alluded to, has certainly made things worse. While no community has been spared, there are important health disparities that have arisen. Indigenous peoples in both countries have been hit particularly hard. Initially, whites were the other most affected group. However, in more recent years, mortality rates have grown fastest in Black and African Americans, increasing nearly 7-fold from 2011 to 2020. In fact, the opioid mortality rate of Black and African Americans surpassed that of whites in 2020. As we discussed in the report, the majority of deaths are among men, and most deaths occur between the ages of 20 and 59. Initially, the mortality rates were highest in rural settings, but as the synthetic opioid wave has built up, death rates in urban settings caught up, and now we see similar mortality in rural and urban settings. And there are geographic concentrations too, with Appalachia, reservations, Western Canada, and New England seeing the highest number of prescription opioids and now overdose mortality. West Virginia is the state with the highest age-adjusted mortality rate at this point, with a rate more than triple the national average in 2020. But more recently, mortality rates are rising in most states and provinces, particularly now that synthetic opioids have spread to markets where they were previously more rare. The Commission focuses on the US and Canada because they are the two countries that have had massive prescriptions of opioids followed by increasing opioid overdose deaths. To give you an idea, in 2012, enough prescriptions for opioids were written in the US and Canada for every adult to have one prescription. And we can't attribute that to people in these countries having more pain. As we detail in the Commission report, a series of regulatory failures and profit motives led to a situation where prescription opioids were recommended far beyond the situations where they may be useful, and the manufacturers downplayed their addiction potential. While this current crisis is mainly situated in the US and Canada, one of our focuses as the Commission is keeping it from spreading around the world. The very same companies that sold prescription opioids in the US and Canada are now heavily marketing them in Brazil, China, India, the Philippines, Mexico, Colombia, and Egypt, among other places. And one of the Commission's key points is preventing the crisis from being exported to other countries. So acting on the recommendations can prevent this crisis from becoming global. And it's important here to mention that two things are true. Opioids were overprescribed in the US and Canada, and there's a vast unmet need for palliative care in lower and middle income countries, including treating pain with opioids. And when we talk about exporting, I want to share a few statistics that really put this in perspective. You know, it's not just marketing, we're also seeing the increase in prescribing. Prescriptions for opioids more than quadrupled in Brazil from 2009 to 2015. And in Australia saw a rise more than 15-fold from 1992 through 2012. And that's why we make the recommendation in line with the previous Lancet Commission on Palliative Care to donate and facilitate generic morphine to countries so that pain can be treated without introducing and fueling this profit motive. Thank you.
Thanks very much, Chelsea. I'm now going to talk about how this happened in terms of regulatory failure and how we stop it from happening again. To give you the key conclusion in a sentence, the opioid crisis in North America was absolutely triggered by the conduct of opioid manufacturers, most famously Purdue Pharma, but certainly not limited to them. And what they did was they aggressively pushed opioid prescribing to a level not seen in world history. I mean, quadrupling morphine milligram equivalents in a little over a decade. That addicted millions of people. It killed hundreds of thousands of other people. But, and it's a big but, it wasn't just them. There was also dramatic failures in regulation, in law, by healthcare systems, and by individual physicians that failed to stop them. And most of those weaknesses have not been fixed. So we spend a lot of time explaining how this happened. And some people would say, who cares about ancient history? That was started back in the 90s, and now most people are dying from fentanyl. We have to care about it because, first off, as Chelsea just said, there's still people dying from getting addicted to prescription pills. But because there is no reason why this couldn't happen again in North America with another addictive medication like benzodiazepines or stimulant medication or ketamine or other drugs we approve in the future. And there's no reason why it couldn't happen in other countries. When a legal drug manufacturer is able to turn the healthcare system into a factory of addiction, it blows away anything an illegal drug cartel could ever hope to accomplish in terms of getting people addicted. So that's why we have to keep caring about this. How did this happen? People are stunned by how this happened. So who don't live in North America, maybe people here are stunned as well, but here's what we found as key weaknesses. So one of them was the FDA official who oversaw the approval of OxyContin with a label that was later shown to be criminally fraudulent, promising less addiction. 1 year later, was working for OxyContin's manufacturer at a very lucrative salary. Other revolving door problems, as they're called, happened at other regulatory agencies. When the Drug Enforcement Administration attempted to stop opioid distributors from shipping truly enormous quantities of pills to very small communities, that industry responded by hiring away key DEA staff to lobby against the agency in Congress successfully. To stop the revolving door from thwarting public safety, the Commission recommends both an increase into the cooling off period, that is how long it is when you work for the public, protecting them from an industry before you can go work for that industry, that needs to be longer. We also say that civil servants who are very talented at regulation should be paid more. There can be incentives on the positive side. If someone is doing incredible work for the public as a scientist or regulator, they should be rewarded for that and not have to run a private industry to get a good salary. Another problem with the approval of OxyContin, and indeed all FDA opioid approvals, is that the agency's mandate historically has been to evaluate whether a drug is safe and effective, looking at a very narrow question, which is, what is the effect on the person to whom it is prescribed if they take it exactly as directed? And in that narrow framework, lots of drugs look really, really safe that aren't. And the reason is it excludes questions like, what happens if the person starts getting addicted to the drug and doesn't keep taking it as directed? They start taking it twice as often, 3 times, 4 times as often. And second, it doesn't ask public health questions about what happens if someone other than the patient takes the drug? What happens if it's in their medicine cabinet and their kid takes it, or their spouse takes it, or they sell it to a friend, or they give it away? We recommend that FDA take a broader public health approach, thinking about not just that narrow question of does the designated patient, if they take it perfectly, come out okay, but what happens to everyone else? And we are pleased to say that there were some sort of noises made about this by Dr. Scott Gottlieb when he was running FDA, and we cite those, commend those in the report. But very recent, just in the last few months, FDA itself has circulated a draft discussion, non-binding statement, but nonetheless a discussion about adopting this broader public health viewpoint on what medications get approved. Another key force in causing this to happen was the marketing of drugs. These were the most marketed drugs, most aggressively marketed drugs in the history of American medicine. Just to give you some numbers, in 2016, the pharmaceutical industry in the United States spent $20 billion directly marketing drugs to doctors. That was quadruple the entire budget of the FDA that year. And we cite data in the report noting that where the marketing was most intense, people prescribed more and more people died of overdose. The Commission, therefore, recommends that the practice of direct marketing to physicians should be banned, as it is in other countries. We also think there should be curtailments on direct-to-consumer marketing. Even though you can't directly market opioids, there are sort of indirect ways of doing so. The only countries that allow that ads for consumers to make therapeutic claims are the U.S. and New Zealand. That is a mistake. It really conveys that everything can be solved with a pill. It leads people to pressure their doctors to prescribe the thing they heard about on TV, and that bumps up prescribing beyond a healthy level. The industry was also successful in part because they were able to set up front groups of allegedly independent advocates who resisted any controls on industry behavior. And they were very persuasive to legislators and to the media. For example, the American Pain Foundation, which billed itself as the independent voice of pain patients, was not independent. It coordinated its messaging with opioid manufacturers, who provided 88% of its budget. In fact, as a Purdue Pharma executive noted in an email that was revealed in the court case, they have no choice but to do what the industry says, because without the industry, these allegedly independent groups wouldn't exist. When that was revealed, the American Pain Foundation dissolved, but that's not the end of fake grassroots groups, or sometimes as they're called, astroturf groups. The tobacco industry really pioneered this with tobacco smokers' rights groups, but it's happening in this space as well. It's happened in other countries, not just the United States. The Commission therefore recommends that creating fake grassroots groups be defined legally as a form of fraud. And also that when corporations file with the Securities and Exchange Commission every year, their financial reports, they have to make fully public which, quote unquote, independent activist groups they themselves are funding. Last but not least, the Commission could not overlook the fact that the ability of the industry to create a legal and regulatory environment that served its interests rather than the public interest was greatly facilitated at the state and federal level by the complete lack of constraints on corporate donations to political campaigns of elected officials in the United States. For example, one study showed that over a decade, pharmaceutical industry lobbying and donations in state legislators exceeded those of advocates trying to put some constraints on prescribing by more than 200 to 1. The Commission thus supports the U.S. restoring the limits that used to exist on how much money an industry can donate to politicians, which could help protect the public in many domains, but certainly in the domain of improving opioid prescribing. I will stop there and turn it over to my friend and colleague, Dr. Howard Koh, to talk about healthcare.
Thank you so much, Professor Humphreys, for your great leadership, and it's a wonderful honor to be part of this commission. On behalf of the commissioners, I'm now addressing two substantive conclusions from the report. First, we conclude that the care of people with addiction is currently stigmatized, marginalized, and underfunded. And as a result, too many people are suffering or dying because they either didn't receive quality treatment or indeed any treatment at all. We also conclude that the threat of addiction is a constant reality of the human experience. It's not a crisis that will just disappear with short-term attention and short-term funding. Rather, addiction, like cancer and heart disease, for example, ranks as an ever-present threat to health and robs people of well-being in so many ways. So to address these conclusions, allow me to review two major recommendations from the Commission report. The first recommendation has to do with building better systems of care. And we believe that health and social care systems should make an enduring commitment to provide services for people with substance use disorders. These services should be fully integrated within mainstream healthcare systems, be equally accessible to all in need, and target a range of outcomes, including, but certainly not limited to, eliminating illicit drug consumption. To implement this recommendation, we can leverage models of care already in use for other serious chronic health conditions. As we all know, in such systems, primary care physicians and other generalists are the first to provide services, either individually or in teams. And then, when necessary, specialists are called upon for added collaborative care and support. Of note, it was only 2015 when addiction medicine was fully recognized as a medical specialty, but that was an important landmark that paved the way for a diverse set of physicians to receive additional training in addiction medicine under the auspices of the U.S. Accreditation Council of Graduate Medical Education. Overall, the goal is to improve patient function and reduce morbidity and mortality. And that's critical even if such efforts do not restore the individual to perfect health. And then, as Professor Humphreys alluded to, care should involve not just the patient, but be much broader, also especially including the family, to consider services addressing related problems that patients may have in regard to issues such as homelessness, joblessness, and parenting, for example. We feel that care systems should have a continuum of services that range from managing emergency interventions for acute crises, like naloxone, for example, to assuring that outpatient and residential care settings are available to provide both behavioral and pharmacologic treatments, to preventing and treating common medical comorbidities through use of, for example, syringe service programs, tobacco cessation and prevention services, and hepatitis B vaccination, to providing mental health services that can address associated psychiatric conditions such as depression or PTSD, and also address the many sequelae of adverse experiences such as child abuse, sexual assault, and violence exposure that are prevalent in this patient population. And then very, very importantly, we believe that this continuum involves supporting mutual health groups and helping move people toward long-term recovery. And that means collaborating with organizations involved in peer coaching and recovering housing and related organizations. So throughout this, ideally, the goal is not absence of disease, but recovery. And each individual defines recovery in their own way. But some common themes include building or rebuilding relationships with people, contributing to the well-being of one's family, friends, and the community, being esteemed and valued by others, adopting productive roles in society, and having a sense of purpose in life. If we do this right, high-quality care systems can help people achieve these goals, especially by linking them to recovery-supporting organizations. Now, the second major recommendation has to do with funding and insurance coverage. And the Commission notes that current funding mechanisms promote marginalized and unstable services, and so we recommend they be replaced with core enduring services and deep funding commitments within mainstream public and private financing mechanisms. And such services should be part of both public and private insurance programs and be fully integrated into the current healthcare system. There are three subparts to this second recommendation. First, we noted that Medicaid is the largest payer of substance use disorder care in the United States, and its role has become even more important in states that expanded Medicaid is the largest payer of substance use disorders care in the U.S., and its role has become even more important in states that expanded Medicaid as part of the 2010 Affordable Care Act. Yet a number of states, including some with quite serious opioid-related problems, have not expanded Medicaid yet to cover more of the population. That needs to be a high priority. We know that Medicaid expansion has been linked to higher rates of substance use disorder treatment and fewer overdose deaths. And then the second subpart of the second recommendation is that we recommend that the federal government require not just coverage of substance use disorder services, but in fact coverage of the full continuum of services in its two largest public health insurance programs, Medicaid and Medicare. We note that despite improvements in coverage in recent years, as I've noted, many state Medicaid programs do not cover all of the substance use disorder treatment services considered essential by the American Society for Addiction Medicine. And then also Medicare and many state Medicaid programs do not cover residential treatment or recovery support services. We note that state Medicaid programs that contract with managed care entities should explicitly stipulate the terms of coverage for substance use disorder care, and ensuring coverage for the full continuum of treatment in Medicaid has the potential to improve access for as many as 1 million individuals with opioid use disorder. And the final subpart of the second recommendation has to do with parity. The Commission report underscores that laws that ensure parity, that is, equality between benefits from mental health and substance use disorders and benefits from medical and surgical conditions covered by a health plan, are now well established. And that means that most private insurance companies are now required by law to not impose policies such as prior authorization or cost sharing on substance use disorder care that are more stringent than those applied for coverage for other medical and surgical services. But unfortunately, some insurers have not complied with the law, depriving people in need of care. In response, some states have successfully brought suit against the insurers who have violated parity. But at this point in time, routine oversight and enforcement of parity should be systematic across all 50 states and be made a national priority by the current administration. So in summary, the Commission believes that these recommendations will lead to a more effective system of care for people with substance use disorders, as well as advance great benefits for humanity at large. Thank you so much, Keith, and back to you.
Thank you so much, Professor Coe. We'll go to my friend, Professor Hurt, to talk about science and its role in understanding and responding to this epidemic.
Thank you very much, and it's very important. The commission was great working with this group of diverse investigators and scientists and physicians. And from the perspective of science, we sadly continue to have debates in society regarding addiction as an illness or moral failing. The commission emphasized that this is a chronic health condition. It is a brain disorder. Many diseases are tied to lifestyle conditions and environmental factors, yet they're not debated as to whether or not they are illnesses. So no matter how it starts, addiction, including opioid use disorder, is associated with pathological conditions as an illness. Unequivocal scientific evidence has established that it's a brain disorder. It's the brain that leads to the changes in mood, cognition, drug seeking, and craving. It's the brain that senses physical and emotional pain. And repeated exposure to drugs such as opioids bring about significant changes leading to alterations in the shape of cells, the firing activity of cells, alterations in the communication between cells, the connectivity between brain regions, and even alterations in gene expression and in the conformation of DNA that regulates how genes are turned on and off, a biological process called epigenetics. So the commission emphasizes that evidence-based science must be the gold standard for understanding the biological underpinnings of opioid use disorders, and evidence-based science must be the standard for its treatment. The range and effectiveness of treatments for many chronic health problems have improved significantly in recent decades. Yet, sadly, the commission showed that this is not true for opioid use disorders, actually, nor for addiction in general. While opioid agonist replacement strategies, which were initiated over 50 years ago, they've been vital for saving the lives of millions of people. But the stigma and challenge of opioid treatments has, as highlighted with this opioid epidemic, really emphasizes that we must develop new strategies to give people back their full lives. So the commission highlighted that, innovative scientific strategies can help develop medications that do not carry a risk for addiction, overdose, or other adverse effects of opioids. So, for example, they highlighted development of biased agonist ligands, which have the ability to activate a particular downstream signaling cascade of the receptor. So, for example, biased opioid agonists could be developed and are being developed that relieve pain but have reduced respiratory suppression and less activation of brain reward circuits that underlie addiction risk. Another non-addictive strategy that is actually also being explored is cannabidiol, CBD, which is a non-intoxicating cannabinoid that is not cannabis. That, for example, my research group had shown in preclinical animal models and then in human pilot clinical trials to reduce cravings and anxiety in opioid users. This established larger clinical trials with the goal of determining whether CBD could be an evidence-based FDA-approved medication as part of the solution for treating opioid use disorder. Also, the commission highlighted the development of non-opioid medication interventions, even virtual reality and nerve stimulation devices. But at the end of the day, the commission points to that the current epidemic with COVID has shown us that what can be accomplished by accelerating science for a crisis. For example, the rapid development of effective vaccines for COVID-19 shows what is possible when governments make a massive, urgent commitment in the face of an epidemic. The same commitment is needed for the opioid crisis. So the commission recommended expanding initiatives such as the NIH Blueprint Neurotherapeutics Network that advances small molecule drug discovery and development projects into the clinic through charging them to focus more medication development for opioid use disorder. Clearly also developing international consortiums would be a game changer. Addiction crosses borders. It is a global crisis and thus require global collaborative and integrative efforts for science to drive biological knowledge and science to drive treatment. Science is also critical for epidemiology. Indeed, there's a significant weakness regarding the epidemiology of addiction. Here too, COVID has shown us what is possible to know. We can know how many people died yesterday in most big and small towns throughout the US and other countries. Yet we don't have similar real-time information regarding opioid use disorder and overdose consequences. It can take over a year to get most, quote unquote, most updated addiction epidemiological data. We need science that with the same commitment and dedication for tracking opioid use and its consequences as we've had for COVID-19. COVID has also given us a model that can be leveraged to provide the benefit of international collaboration. For example, again, the type of products that promote addiction are constantly evolving. Thus, an international tracking mechanism would allow us to begin to move more quickly to find solutions much earlier than waiting until X amount of people have died. The goal is to prevent epidemics, not having to constantly react when the dam has burst. Also, an important aspect about the opioid crisis that sometimes may get underappreciated is the emphasis on the developing brain. Approximately every 15 minutes, a child in the US is born with neonatal abstinence syndrome. Moreover, the opioid crisis exposed many children to parental opioid addiction and many teens themselves now using opioids. As such, another big area where science is critically needed relates to brain development. There is significant scientific evidence that early drug or opioid exposure has long-lasting impact that can affect health even long into adulthood. Moreover, stress and adverse environments can compound addiction risk, particularly during brain development. So reward-rich environments are important for helping to promote healthy lives as people age into teenagers and adulthood. So these are just a few of the topics, but overall, the Commission believes that we need to lay the foundation for the global collaboration, creativity, and innovation needed to truly develop new evidence-based treatments for this continuing devastating opioid crisis. And COVID-19 has clearly created a greater awareness about the importance of global science and the need for global scientific solutions. Scientists here must play a leading role, not just at the lab bench, but in policy, regulatory matters, and education of the public. So with that, I pass it back to Keith. Thank you.
Thank you so much, Yasmin. It's terrific. We're now going to move to our dear friend in Canada, Professor David Yerling, to talk about opioid stewardship and pain medicine. David?
All nations should have a pain strategy. The U.S. actually put one of these together in 2016, but didn't do a lot to fund or adopt it. And I want to make the point that the pain strategy is not the same thing, is not simply an opioid strategy. The idea here is that pain is a universal human experience, and chronic pain in particular affects hundreds of millions of people around the world. And it is simply a fact that people in pain are more likely to receive better care, whether with opioids or not, if the care of pain is embraced as an urgent societal priority and organized in a rational fashion. So one of the Commission's recommendations is that all countries develop a comprehensive pain strategy that does a few things. First of all, emphasizes and embraces an interdisciplinary approach to care, as opposed to a doctor just giving a patient a prescription and sending them on their way, engaging nurses with special training and pharmacists and pain psychologists and physiotherapists and occupational therapists to help these patients deal with pain in a much more holistic and comprehensive way. Pain strategy should also be based on the best available evidence. It's fair to say, don't have a great deal of evidence around the long-term effectiveness of many of the drugs we use for pain, but we do have some, and that needs to be taken into consideration. These strategies should address both the prevention and treatment of pain and the prevention and treatment of addiction as well. And importantly, critically, I would say, alluding to Keith's comments from early on, these comprehensive pain strategies must be insulated from the effects and the influences of the pharmaceutical industry and the medical device industry. Their goals are understandable, but they are very clearly at odds with our obligations to our patients. The second recommendation I want to touch on is that policies around opioid prescribing need to be sensitive to the needs of different subpopulations. And so it is fair to say that there are three kinds of people out there. There are people who are suffering right now from opioid addiction. That's on one end of the spectrum. On the other end of the spectrum are people who aren't on opioids at all. They may one day be, and they will have pain, and they might find themselves on opioids, but they currently are not. And in the middle are people with chronic pain who are currently on opioids, generally from well-intentioned prescribers. It is essential, I can't overstate this, to realize that responding to system-wide overprescribing by throwing a switch in the opposite direction, never prescribing opioids at all, or drastically lowering a chronic pain patient's dose, or cutting them off altogether, that can have disastrous consequences for people in pain. Existing stewardship initiatives and guidance documents in the US and Canada and the UK emphasize the expanded use of effective non-opioid alternatives. That will very much depend on the patient. But the whole idea here is that opioids are essential medicines, but if we can rely on them less, that will, I think in general, accrue a net benefit for patients in pain. Tapering patients on opioids, the so-called legacy patients who have been on often very high doses for many, many years, needs to be done very, very carefully. It's a very highly individualized process. It has to proceed slowly, and it has to be done by people who are trained in it and know what they're doing and are compensated for it. Canada's Deprescribing Network is a promising effort to normalize this practice, not just with opioids, but with antidepressants and benzodiazepines and so forth. The U.S. Department of Health and Human Services guideline deals quite well with the complexity of tapering opioids, including shared decision-making to help foster a patient-centered and collaborative approach. And the third point I wanted to make is that is the Commission's recommendation that policymakers in the U.S., Canada, and other countries should implement more effective procedures to reduce the supply of excess opioid pills. Now, this is a bit of a hot-button issue. The idea that there should be fewer pills in circulation, or that there's excess prescribing in the first place, is a real hot-button issue. I mean, especially for chronic pain patients, and for the doctors who care for them, and for people who view the crisis as solely one of addiction. It is true that curtailing the supply of opioids does nothing to treat addiction. And it can, if done in a ham-handed fashion, harm people with chronic pain, especially if they are tapered quickly or thoughtlessly. But it has to be said that flooding a nation's medicine cabinets with opioids is harmful to individuals and to society as a whole. We saw that happen. We watched it in real time. So everybody with opioid addiction has, by definition, a first exposure to these drugs. Sometimes it's prescribed to them and the addiction evolves in the course of well-intentioned therapy, but more often than not, the pills are obtained from someone else, from a medicine cabinet, from a grandmother, a parent, you name it. The goal of this recommendation is to reduce the incidence of opioid addiction going forward. So how to reduce excess supply? One is prescribe more cautiously. I think, this is a bit of a personal bias perhaps coming in here, but fewer new starts on opioids for both acute and chronic pain, but especially acute pain. Smaller initial quantities, far less in the way of dose escalation, the sort of thing that I myself did 20 years ago rather liberally because I thought it was the right thing to do. So prescribing opioids in a different way, especially for new patients than we did, say, 15, 20 years ago. But also the disposal, promoting the disposal of unused tablets. In many developed countries, governments require that opioid manufacturers and distributors fund medication disposal programs at convenient locations like community pharmacies. The US, though, tightly regulates drop-off procedures and doesn't ask the private sector to absorb the costs its products generate. So for the first 15 years of this crisis, that meant that efforts to reduce the supply of unused pills were limited to prescription take-back days, which are operated, a few times a year by law enforcement. So those efforts are valuable, and they certainly raise public awareness of the importance of getting rid of medications that you aren't going to use anymore. But they're not sufficient as a policy response, because opioids were really only a tiny proportion of the drugs that were returned during events like that. In 2010, the U.S. Congress expanded the number and types of organizations, pharmacies and hospitals, that can be licensed to collect and destroy unused controlled drugs. But by 2017, only 2.5 of eligible sites operated programs like that. And so the Commission recommends that the U.S. follow the example of other countries, including Canada, that operate more effective take-back programs by mandating that accepting unused medications be a required activity for hospital-based and community pharmacies. As in other countries, the cost of these programs should be borne by manufacturers and distributors. Reflecting on the early days of glass recycling, maybe a financial incentive might initially be needed for the public to help adopt the habit of returning unused meds until the behavior becomes more commonplace. And finally, policymakers should consider experimenting with requiring opioid manufacturers to fund a program that would reward pharmacy customers who return the unused portion of their prescriptions, especially controlled substances. For example, a discount coupon for in-store purchases. So I'll leave my comments there, and thank you again for your time.
Thank you so much, David. So we've come to the end of our formal presentations. Thank you to all the speakers. Those were terrific talks. I just want to make a few quick closing observations. One is we only have a subset of commissioners here, and because of time, we only got into a subset of our recommendations. So I want those who are watching to know that you can read about who all the commissioners were, as well as see every single recommendation in the Lancet, and also on a website we have at Stanford University, which is opioids with an S, so it's opioids.stanford.edu, opioids.stanford.edu. Last thing I want to say is it is very easy to despair at so much suffering for so long, but we can't give in to that, because without some optimism that things can change, they never will change. So I just want to mention two positive things that have happened. So first, Professor Coe and I worked for President Obama during the passage of an act in the United States formerly called the Affordable Care Act, but known often shorthanded in media around the world as Obamacare. That gave insurance to tens of millions of people. And although it was not an addiction-focused bill, it in fact has been transformative for the care of addiction. For example, expanding out the Medicaid that Howard mentioned, that has now become the backbone of drug treatment around the country. It has saved many, many lives, including even in the state where I'm from, by the way, West Virginia, the hardest hit state. The fact that they expanded Medicaid has made their situation much better than it otherwise would. Policy matters, and policy can change. The other optimistic point is this. Addiction is a very, very terrible condition to struggle with. It claims many lives. It causes lots of suffering to the person and also to everyone around them. At the same time, representative survey data show that in the US and Canada, there are about 25 million people who have had a serious problem with a legal or illegal drug, alcohol, heroin, OxyContin, cocaine, what have you, and are now in recovery, are now productive and healthy and happy and back with their families. And people do, in fact, get better. And we need to tell those stories too and remember them, that this is not hopeless. No individual is hopeless, and this situation is not hopeless. Lots of good things happen, and we can make more good things happen. I will stop there, and now we can open it up for your questions. Thank you. I'm having a little trouble opening the question line here. Okay, here we go. I've got it. Thank you. Okay, so this question is from Jonathan Rosen, and it is, a policy gap has been the workplace as a pathway to addiction, where occupational injury or illness treated with prescription opioids or occupational stressors leading to self-medication. Workplace drug policies emphasize discipline rather than support and access to treatment. I encourage the Commission to look at an issue of New Solutions Journal. Anyone want to comment on that about the workplace issues around how we respond to pain?
Maybe I can just say, Keith, that in the context of the pandemic, I think all employers are much more aware and concerned about the broad health of their employees for so many reasons. The isolation, the stresses of the workplace in this current environment. And there's more efforts, I believe, by private industry to pay attention to health of employees, broadly speaking, not just physical health, not just in terms of pressure checks or gyms or that sort of thing, but more broadly in terms of emotional well-being. So I think this theme can be something that can move forward, especially since everybody in private business now sees how private business and public health is inextricably intertwined through COVID-19.
Thank you, Howard. Here's a question from Professor Ayanna Jordan. I am concerned that so far racism in addiction research, representation of the physician and other clinical workforce, and treatment of patients has not been discussed as a key contributor to the crisis. How does the Commission consider the role of structural racism, its impact on opioid use, engagement, and treatment? This is a very important question. I'll tell you a little about some of our analysis of this in the report. So we point out how racial and ethnic discrimination results in disparities of care in different directions. So for example, First Peoples in Canada, the lack of inbuilt health systems on their lands means that you have fly-in physicians who basically turn up and they tend to just write a bunch of prescriptions and then they get on a plane and go home. If they had adequate structures of support, if they had physical therapy, comprehensive care, they would have more options, and they don't, and that is a function of racism. We also point out that African Americans were denied adequate pain relief due to, in part, racist beliefs about higher tolerability of pain among African Americans, a racist idea that goes back at least as far as slavery and probably longer, and that is unjust. We also point out about when we write about toxic environments, why are people in environments that are lacking in reward, and why do we focus so much in the report, for example, on low-income kids particularly? And there are many mechanisms for that, but one of them is clearly racial and ethnic persecution and disparities in the allocation of resources. And that translates over decades into higher risk and higher environmentally driven risk for addiction among people who are oppressed racially or ethnically. There's also quite a bit about disparities in Port. Chelsea got into some of it, but it's a very detailed analysis that she's put together. I don't know if Chelsea, if you want to say anything more about that.
No, I think you hit the main things that I was going to say. I mean, we do, and I know, Dr. Jordan, I'm happy you're tuned in because I loved your paper that came out yesterday that really dug into some of the types of disparities that we see at the state level, which we touch on in our epi section and talk about how, basically in most states where there's enough population diversity to look at racial and ethnic disparities in terms of opioid overdose deaths, you see massive gaps. And I regret that your paper came out yesterday because I would have loved to cite it when talking about that. But of course we had it in earlier.
Thanks, Chelsea. Here's a question from Michael Newberry, and I hope I said that name correctly. I think this would be for our physicians. It's how can we improve efforts to screen patients for addiction before any substance with potential for addiction is prescribed? Also, should buprenorphine be prescribed more often for acute pain requiring an opioid so as to diminish the exposure to a pure opioid, I assume meaning a full agonist?
Do you want me to tackle the part of that, Keith? So
yeah, I think you and Dr. Koh are the experts here. So
yeah, so screening people for, addiction has a very large genetic component, and there have been, tools developed over the years to try and predict who would develop aberrant opioid behaviors during the course of opioid therapy. The problem is that they're just not very good. you can demonstrate a gradient. You can show that people who have a history of, childhood sexual abuse or a history of mental health disorders or heavy alcohol use are more likely than people who don't to develop features of opioid addiction. But it's even in people who rank low on scales like that, it's aberrant behavior still emerges. So I think it's very difficult to know. Before I put a patient on opioids for acute pain or chronic pain, it's very difficult I can have some red flags or some aspects of the person's past history that tweak me to the possibility that maybe this is someone who isn't a good candidate for opioid use. But you can have someone who is devoid of all of those features and who nevertheless it manifests over the course of months or years features of opioid addiction. And so I think it's actually it's not the sort of thing that we can screen for easily. And I think we are much better off trying to be more cautious in how we use them. And this is one of the points I made earlier. Start them less readily. Accept what the evidence shows us. That there's a widespread perception out there among clinicians that opioids are somehow more effective analgesics than, say, nonsteroidals, or that they are safer than nonsteroidals. And there will be some people in whom that is true, but it is generally not the case. So starting them less readily, escalating doses is something I did liberally 20 years ago, and it's only with the benefit of hindsight that I realized how much I harm people with that practice. And not giving people 30 days worth of meds when they're only going to need 4 or 5 if the history accords with that. So I am optimistic that in the future, and maybe some others on the other commissioners will have thoughts on this, but I'm optimistic we'll be able to do a better job of predicting who is prone to addiction, but I think it can happen to anybody.
And if I can follow up the report spends a lot of time talking about the need for a system of care that involves generalists, primary care physicians, and then also specialists, addiction specialists. We need everybody to be involved. The role of generalists in particular, their responsibilities and education here needs to be improved so that we're all committed to case finding and earlier detection and then adequate and optimal treatment for people. For example, there's language in the report about making sure that there are addiction consult liaisons in emergency departments, for example, to help with case findings. And then when we identify people who have addiction risk or are wrestling with addiction, that we connect them with services as soon as possible. And then if you want to keep going into this, there is some debate right now about the X waiver and Xing the X waiver. Keith, I know you've written about that, so you may want to comment more. But I think the overall message from the commission is we need all clinicians, especially all generalists, to be more educated, more engaged, and more involved in prevention and early detection of people who are wrestling with these conditions.
Could I make, Keith, just a quick additional point?
Of course.
So implicit in the question is that addiction is sort of the dominant long-term harm of opioid use. And I think it's really important to step back and reflect on that. I want you to imagine a patient who, with chronic back pain, who's put on opioids by a well-meaning doctor, and who over the course of many years escalates to, let's just say, for argument's sake, 200 or 300 milligrams of morphine a day. That might seem like a lot, depending where you're watching this from, but 10 years ago, those patients were all over our wards. Millions of people in North America on long-term opioid therapy, very often at very high doses. And even if they weren't exhibiting the characteristic features of someone with addictions, frequently losing their medications, losing them down the sink, double doctoring, going to multiple pharmacies, even if they were just doing what their doctor told them to do, I think, and this is anathema to some patients in the chronic pain community and some doctors, I think the case is easily made that patient has been harmed, even if they're not addicted. They continue on opioids, and they must continue on opioids because the alternative is misery and withdrawal, and they and their physicians will form the perfectly understandable impression that the opioids are helping them, because without them, they are horribly sick and maybe even suicidal. But it is simply true that even in someone like that, who has no features of addiction, the primary benefit of the drug in that patient is keeping withdrawal at bay. With opioid withdrawal that is itself a consequence of opioids changing the structure and the function of the central nervous system. We don't think of that as a harm, but it really very much is. And so I just want to of course, not dismiss addiction as a phenomenon, but point out that we harm people all the time, yet fall short of provoking addiction.
Next question.
Also just
sorry,
quickly,
go ahead.
No. I just want to quickly add one thing. We're going to continue to have this kind of debate unless we enact some sort of national, global type of monitoring. It's research on thousands of people that are necessary. So even if there are certain structured questions, there are structured monitoring, certain structured tests that everyone does, every patient, and that goes into a database, we're going to still have this. It can't be just, the individual clinician with their individual patients. It's absolutely, that is the start. But it's the collective, it's that globalist data. And for whatever reason, in psychiatry and addiction, we don't have this as with the COVID has taught us, you need global data to be able to identify truly people at risk.
Let's stick with you, Yasmin, because I think the next question is certainly in your wheelhouse. This is from Rupert Rowe. Is there any meaningful difference in addiction risk between any of the opioid molecules or the types of formulations available today?
Yes, there are definitely differences. It depends on the potency of how these opioids interact with, for example, the opioid receptors, the mu-opioid receptors. So those that have higher potency tend to be more addictive. So drugs that enter the brain quickly and leave quickly, the pharmacokinetics is also a profile that you can look at to see what would increase addiction risk. So we do know, so fentanyl, extremely potent, and that's what's causing a lot of the more recent deaths, much, much more potent than morphine. And we continue to make, well, not us, but synthetic opioids continue to increase in potency, especially since you don't need the agricultural issue of like morphine. And so this is going to continue. We're going to continue to have new analogs. And so as the government will, have laws against one analog, a new one will come up. And that's what the commission, we really emphasize these issues that the government needs to take a much stronger role. And how do you look at this as a global issue rather than an analog per analog per analog? But yes, its potency and how it binds to the opioid receptors, how it goes, the speed with which it enters and leaves the brain also contributes to the addiction risk.
Thank you, Yasmin. I see multiple questions in here about criminal justice, so I'm going to just summarize our recommendations in that domain. So first, we made an observation that there will always be contact between the criminal justice system and people who are addicted, regardless of whether drugs are legal or illegal. And we note that you can see that with alcohol. In the United States, it's legal, but it is the #1 drug involved in arrest, violence, and incarceration. So given that that is true, we thought, how do you get the good things you can get out of that and avoid the destructive things that you get out of that, particularly in low-income and African-American communities in the United States? And we said a couple things. One is that the criminal justice system tends to remember that it's supposed to punish and it's supposed to incapacitate, but it often forgets it's also supposed to rehabilitate. That's one of its core goals. And therefore, we say every single correctional facility has to provide addiction treatment, including all FDA-approved medications. There are some that will not provide the opioid agonist therapy. That is wrong. Those are very effective. We highlight a terrific program in the state of Rhode Island that gets people on to buprenorphine from their first day and has dramatically reduced the overdose death rate. So that's first on the positive side. It's also a chance to do other things like hepatitis B vaccinations, dealing with mental health and so on. That would be aided by the passage of the Medicaid Reentry Act, which is currently under consideration in Congress, which would turn insurance back on while people were still incarcerated. Currently in the United States, it turns off the whole time that you are there. We also recommend rolling back punishments that, in our judgment, do more harm than good. And the three areas we focus on are jailing people. We don't put people in a full prison generally for just using a drug or possessing a drug, but we certainly jail people. What happens when you go into a jail when you are addicted to opioids is, contrary to what you've seen in the movies, it's actually hard to get a regular supply of opioids when you're incarcerated. So almost everybody goes through an awful withdrawal, and then they lose their tolerance. And what that means is when they come back out and they use their usual dose, it can be lethal for them. So you're doing all that harm, and it seems to us cruel and unusual kind of punishment. And there's no evidence that it deters people from initiating opioids that happens. So we just think that should be eliminated as a practice. Secondly, there are a lot of collateral penalties, and I saw a question about this. What about somebody who's done something, maybe they had an addiction and they sold drugs 20 years ago? Why do we keep punishing them forever? Those are called collateral penalties. Things like, now you can't get a student loan for the rest of your life. Now you can't get into public housing. Now you can't work. You'd like to work in childcare. You want to be a teacher. You can't. We don't punish people who commit murder that way, but we punish people who have drug problems that way. We are against all of those collateral penalties. The last thing has to do with pregnancy. A number of states define a pregnant woman as a criminal if she uses a substance during her pregnancy, as if she were treating it like child abuse. And evidence is that those kinds of laws, maybe they are intended to protect, fetal health. Let's give the benefit of the doubt that is the intention. It doesn't work out that way. It's worse for the parents. It is worse for the babies to be. And so we think all those laws should be repealed. In fact, we should be doing just the opposite. We should be making high priority access to during pregnancy. I mean, that is a place where you can have a massive benefit. You treat somebody's addiction during pregnancy, not just for them, but then you're setting their kid off on a really different life. So an entirely therapeutic approach, not a punishment-focused approach. Here's a big question from Kathy Burke. I presume my friend Kathy Burke from Stanford. How do we address the commercial determinants of health? What countries are effectively regulating the power of private industry? Sometimes silence is a form of speaking. David, do you want to talk a little? I mean, Canada is a bit different than the United States, where we tend to be more corporately freewheeling. I'd be curious what your perspective is from Canada, if it's doing any better despite the suffering than the U.S. did.
I don't think we're doing a whole lot better. I mean, people have access to free healthcare. We don't have to quibble about whether they're insured or not. We don't need. We don't have the same restrictions on access to buprenorphine and methadone as buprenorphine in particular as in the States, and we aren't. While we don't have the influence of direct-to-consumer advertising, to go to your previous point, we certainly get a lot of American TV, so we sort of get it en passant. I don't think we're doing a whole lot better than you guys south of the border, Keith. I mean, we have the same problems. We have deaths are roughly of the same magnitude. Our prescribing is just in MME is just a little bit behind yours, but corporate influences are very difficult to expunge.
And this is one of our principal worries about the opioid epidemic spreading. If companies can evade regulation in wealthy countries that should have a lot of resources to resist them, then it's only easier for them to resist, overcome regulation in countries where literally their profits could be, as big as the GNP. And we really hope that, those nations will not be abandoned by the rest of the world because they're going to need help. I mean, there's already been cases, pain practice guidelines being written more or less by industry in other countries, and that's really just going to be a disaster.
The influence of pharma can be quite subtle. I mean, all it really takes, let's imagine I'm a physician in Brazil or the Philippines or South Korea, where manufacturers have a very solid toehold now, and I am told by a prominent thought leader that opioids are a safe and effective treatment for chronic pain, that the incidence of addiction is low or infinitesimal, as we were told, that they are more effective than or safer than non-steroidals. You know, if I went into medicine to help people, which most doctors did, I would be happy to hear this message. I've suddenly got access, especially if my regulator approves it, despite the absence of data to do so. But I'm happy to hear this message. My goal as a doctor is to alleviate suffering, and now I've got this extra tool that I didn't have a few years ago. I will deploy it freely because I went through this. If I see I'm a bit hot on this topic, it's because I went through it firsthand. I trained in medicine in the early 90s, and I saw lots of patients with gastrointestinal bleeding from nonsteroidals, and lots of patients with acute kidney injury from nonsteroidals. And I knew that that wasn't going to happen with opioids, and so I was quite happy to deploy these drugs liberally, not realizing that there's a lot more to opioid receptors than just pain relief. I mean, we take this highly evolved and very important receptor system that has a role not just in pain transmission and bonding and reward, and then we flood it with massive super physiologic concentrations of agonists for months and years at a time. We cannot be surprised that things go awry. And I hope that doctors in other countries don't find themselves 10 or 20 years hence looking back with that same regret that I have. And the influence of pharma can be as subtle as simply encouraging them to be good doctors.
It's a really nice question from John Pantal. I hope I said that correctly. How do we change public expectations and behavior in relation to opioid use, even when we sort out the weaknesses in regulatory and professional practices? So this is one reason why we focused on advertising in the report. Where do people get the expectation, first off, that there is a medication for everything and what it does? A lot of them get it from TV, from the internet and the media, and those messages are created by industry. Even when they don't directly advertise their product, they define how a disease is understood, or the fact that even something is treated as a disease is resolvable. And we think that, constraining that and replacing it with, as David mentioned, something like the National Pain Strategy, where you have a public service directed campaign free of industry influence that gives people accurate information about pain, would be a better way to shape expectations. We also note that some of this stuff is cultural, and culture is hard to change. We just make this as an observation in the report. If you look at Canada, Quebec prescribes far less, has far less opioid addiction than the Anglo parts of Canada. The French-speaking parts of Switzerland have lower rates than the German-speaking parts. France has a different conception of opioids, and I know the expectation that your doctor will fix everything is not as prominent. I have noticed that's an anecdotal thing in France, that there is a pill for everything, and those kinds of things also feed in, and they're hard to change. But it does make a difference. I think the concept, whether culture conceives that all problems are resolvable and pills are the answer or not, as opposed to some problems can't be fixed, even a good doctor can't fix everything. Here's a question I think that anyone...
Keith, can I add to that?
Yes, please.
In terms of public perceptions, I want to broaden your very nice answer, Keith, because you mentioned, and I was delighted you did, that some 25 million people are in recovery, and we just don't hear about that enough. I know the people I know who are in recovery are unsung heroes, and they have demonstrated that recovery is possible, and they can go back to leading meaningful and productive and joyful lives. A lot of them, however, don't want to talk about their journey because the stigma is still so high. So I think the more the public can be involved in celebrating people they love who are in recovery, encouraging conversation of this whole challenge as a medical issue, and overcoming the stigma. And then the report under your leadership, Keith, was very careful how we use the language of substance use disorder as opposed to substance abuse, for example. There's been a lot of discussion about using the right terminology and encouraging the public to do so. So this is viewed as a medical condition and not a moral failing. So I think those are some of the things that might help address the previous question.
Thank you. We have a question from Woody Khan. It's addiction medicine, for example, in the UK Royal College of Psychiatrists has been shrinking drastically. How do we rebuild its numbers and experience? Let's widen that out. How do we not only get more physicians interested in treating addiction, how do we get more scientists interested in addiction? I think anyone on the panel could respond to these questions. I'll just throw it open, whoever would like to go.
I mean, from a scientific perspective, and I think Dr. Ho just brought up a point, the stigma is an issue. And I think when people think that there's no hope for those patients that, this is a disorder that can't be treated, that's why it's very tough to get, young clinicians and scientists into the field. But I will say, one of the things from a scientific perspective, after studying the brain now for decades related to substance use disorders, it is clear, and I mentioned quickly in my intro, that a number of the changes that we see in the brain relate to epigenetics, meaning, changes in our DNA structure that regulate how genes and therefore downstream proteins and receptors and everything else in the cells work. The thing about epigenetics is that it's reversible. So I think that as scientists, we all often emphasize what we see that goes off in the brain, but we don't emphasize what we have learned. And learned in the context of epigenetics is a reversible mechanism. So those are things that I think science and scientists are now focusing on, these epigenetic mechanisms. Can we really develop medication? So I think once we use science to bear to provide clinicians with more tools, you'll have more clinicians going into a field where there are options to actually positively influence the lives of their patients through medications that are available. So I do hope that we bring more scientists into this field, because I as I said, learned a lot that the changes that we see are not permanent and that people are damaged for life. I think that those types of messaging has to stop. It all contributes to the stigma, and decriminalizing substance use disorders will make a huge difference in also bringing more people, I think, on the medicine and scientist side to the field.
Thank you, Yasmin. Anyone else want to comment on this?
Well, just to reiterate my comments, the report did mention very prominently that it was the year 2015 when addiction medicine was formally recognized as a specialty by ACGME. So I think that's a very important signal for the future of the field. If young clinicians and physicians and healers of all background view this as a recognized, very important area for the future health of our country, they can have rewarding careers in terms of patient care, but also research and also in academia. That people specializing in addiction research, like you, Keith, if I can say, can be promoted and recognized and lead very important national conversations. I hope that'll encourage the next generation, because this has been overlooked by the health professions for far too long. But I think there's a new era now, especially since that field is now being recognized in the way it is.
Thank you, Howard. There's a question here. I haven't heard much about prevention. What do you say about prevention? I'll say a little about that and then let others chime in. So some of the preventive things are about the supply of opioids. So collecting up the billions of pills, and it is billions of pills every year that just collect in American homes, is a form of prevention. Having physicians prescribe judiciously is a form of prevention. We also talk about prevention with kids. And we emphasize a concept called horizontal prevention, which we did not invent, but we picked it up from work like by Marie Thiessen in Australia. And that's the idea that rather than run a drug use prevention program, and then an alcohol use prevention program, and then a bullying use prevention program, and then maybe a educational failure program, that prevention be horizontal. It target core risk factors in kids and environments that predict virtually every problem we worry about kids developing. And those are things like toxic and disordered environments, but they're also, for at the individual level, things like the ability to recognize emotion and describe it, the ability to connect with other human beings, the ability to exercise behavioral self-control. And if we stopped all these boutique programs that kind of treat every single problem like it was almost due to an individual gene or germ, and recognize these are really core risks in environments and core capacities in kids that we should be strengthening. We also emphasize that not everything that prevents addiction, again, in kids, is even labeled anything to do with addiction. So, we highlight nurse-family partnership. That is for during pregnancy, prenatal care for low-income parents-to-be, where a nurse visits, gives health advice, support, and follows that through birth and afterwards. Kids in those programs, in almost every trial, have lower rates of smoking, drinking, and using drugs later in life, even though that's never even mentioned. But it's making an investment in people who are in difficult environments, and that helps them get on a different path and have the connection, meaning, and also the brain health that Yasmin was developing. And so we can think more broadly. A lot of just basic investments, particularly towards young people growing up in stressful, low-income environments, can translate into addiction, even if that's not their official purpose. They can still have that purpose. Whether you'd like to comment on prevention?
If I may, I have a couple of things. So I appreciate that overview of a lot of the sort of primary prevention we talk about to prevent people from developing substance use disorders in the first place. We do spend a lot of time in the report also talking about secondary prevention, which, as an epidemiologist, is the idea that, preventing people who already have behavior from it becoming worse and becoming a disorder. And then tertiary prevention, which is really where I focus on, which is looking at folks who already have a substance use disorder or are using substances, and how do you prevent them from dying or having other bad outcomes. And we do spend a lot of time on this in terms of talking about, and I saw there were some questions in the chat around fentanyl and what do we do about that? We spend a lot of time talking about that. We spend a lot of time, we also talk about how, the nature of the synthetic drug crisis as it is now means that it's not just people who are intending to use heroin or opioids who are dying from synthetic opioids. And that's one reason we make the recommendation that even people who use stimulants and folks who are using pills, which could be counterfeit pills made as fentanyl pressed in to make them look like oxycodone, making naloxone available there. And we talk, I'm really happy about the parts where we also talk about some of the ways that we can use technology to try to address the fact that, most people who die from an opioid overdose now are alone and, don't have to be. And really talking, and this gets to the stigma point, but also about how can we use technology for people to be basically cared for, even if they're physically by themselves. And, that comes with reducing stigma so that it's not a secret. And it also comes with potentially using technology to do things like remote monitoring for people to look out for them.
Thank you, Chelsea. Here's a question from Sandra Hyde. What about harm reduction as a strategy? So we embrace public health, and we actually say that the distinction a lot of people draw of do you favor harm reduction or do you favor use reduction because let's have a fight is actually empirically unsustainable and also just rather silly. You don't hear that in other parts of medicine. A doctor who can cure someone's pain entirely and another one removes 50% of symptoms don't get into a fight about pain elimination versus pain reduction. They both say, well, I did good work today. And we just say it's all part of public health. So, when you give naloxone and save somebody from an overdose, when you use needle exchange and stop them from getting an infection, you are advancing public health. And so is the person so is Alcoholics Anonymous and 12-step groups that make people stop using heroin. That's also advancing public health. And contrary to how these issues are often drawn as very oppositional, we cite just the facts. Most people who reduce risk then reduce their drug use. If you follow people who get access to syringe exchange, they're often using less drug use. People who are on buprenorphine, who go to 12-step meetings, have better outcomes than those who don't. So in real life, ordinary people sort out how to pick and choose what they need to get healthy. And if they can do it, the people who can provide can also do it, and just work together. We're all on the same side. We're trying to advance public health, and harm reduction is an honorable role in that, and always will. Okay, here's a question. I'm actually particularly curious what you think about this, Howard, but anyone can chime in, of course. Srinivasa Murthy asks, how important is it to build social cohesion in preventing drug use in the community?
Well, I think that's a key question, and there's a lot more attention now on social supports and connection to community as part of overall well-being. If I can say, I was very proud that the report talked a lot about the elements of recovery and connecting with other people and rebuilding relationships and finding a sense of purpose in life. I think those are some of the themes we're going to be hearing a lot more, not just in the field of substance use disorders, but in terms of public health in general. You know, we spent too much time maybe in medicine and public health doing research on disease conditions or absence of disease, and not enough on what gives us true well-being in a positive sense. I have a colleague at Harvard, Tyler Vanderweel, who talks about flourishing and has established a so-called flourishing index, in fact. So I think the rebuilding of community connections for people who are wrestling with substance use disorders, community cohesion, this is where the emphasis on community prevention that you mentioned, Keith, is so important. I think that's going to be a really important theme for the future, because let's face it, we can't be healthy unless we're connected with a community that is helping us as well. So I think that's where the discussion for all of us in medicine and public health are going.
Thank you, Howard. Anyone else want to comment on that? Okay, let's move on. Here's a question from Andrew Kolodny. To improve surveillance of opioid use disorder, should the United States adopt a confidential reporting system similar to HIV? We didn't actually get into that in the commission. I've not heard the idea before, but we've certainly got some knowledgeable people here, so I'd be curious what they think of that.
I mean, I can take it if no one else wants to jump in. I have a few thoughts.
Well, you're an expert in HIV. Yeah, please do.
Yeah. I think the issue of improving monitoring in terms of knowing what the current situation is in terms of how many people have opioid use disorder, what are we looking at with fatal and non-fatal overdoses, is absolutely critical. And that's the part of this that we did get into in the commission. I think the idea of a confidential reporting system, I haven't really thought about this so much as to sort of accept to know that, one issue while we live in this society where there's so much stigma around OUD, is that, anything, similar to what we've had with HIV too, is, kind of to what end would we be reporting it and doing it, but really fostering a place where we can have clear-headed and accurate and up-to-date understandings of the scope of a problem is really, really important. And it's very challenging to do right now, both because of the stigma and the limitations in how our data and reporting are set up.
Thank you, Chelsea. We are at just about 90 seconds left. So let me close by again saying thank you. Thank you, Richard. Thank you, Beck. Thank you to the Lancet. Thanks to all the terrific speakers and also all the other commissioners who are not here today. And thanks to everyone who's tuning in. You would not be doing that if you didn't care and want to help on this issue. And we need every single one of you and more. So thanks for your engagement, and be well and happy.
And thank you, Keith.
Thank you.